Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. Our program tonight focuses on OBGYN issues and maternal fetal medicine. We'll talk about what goes on during an OBGYN visit, touch base on the plethora of other issues females face with their reproductive organs. During this next hour, we'll have experts answering questions about maternal fetal medicine. So stay with us and think of some questions of your own that you may wish to ask this evening. Call us at 881-0013. You can also ask us your questions by computer, tablet, or phone as we're streaming live on Facebook. Just go to KCOS TV in the search bar. This evening's program is underwritten by the Hospitals of Providence. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing medical students to man our phones, and the El Paso County Medical Society for bringing this show to you. Good evening. I'm Patty Tiscareño in for Catherine Berg, and you're watching the El Paso Physician. Well, good evening. I'm so pleased this afternoon to welcome two physicians, Dr. Maria Velasquez and Dr. Andres Flores. Now, they're both obstetricians and gynecologists, but Dr. Velasquez, I understand your subspecialty is neonatal perinatal medicine. So if I can begin with you, would you tell us a little bit about what that specialty involves and what you do all day, every day?
Yes, ma'am. Thank you for having us. My specialty is actually not neonatal, it is perinatal. So that means that I specialize in high-risk pregnancies, whether that means that there's a condition that makes the mother high risk or the fetus high risk. And basically it's a consultative practice where I assist the general OBGYN physicians like Dr. Flores with their patients so that we can have the best outcome possible.
Wonderful. And Dr. Flores, can I get the same from you? Tell us a little bit about what your practice entails and how you do work collectively with a neonatal and perinatal specialist.
Of course. Thank you for having us here.
Of course.
And as Dr. Velasquez said, we take care of pregnancies for the most part, and some pregnancies that deviate a little bit from what we consider normal. Then we have Dr. Velasquez's help in managing conditions like, let's say, a patient who has pre-existing diabetes, hypertension, thyroid problems, conditions that puts her pregnancy at a high risk level.
I see. Well, I was talking to Dr. Velasquez earlier tonight and telling her that this is such a great opportunity for me because I have a 38-year-old daughter who is currently pregnant, due in July, and she is called not necessarily high risk, but advanced aged pregnancy. So can we talk a little bit about that, what that means, what makes someone high risk, and how can you really help someone get through a pregnancy so that they have a healthy baby at the end of the term?
Sure. So the patients that are labeled advanced maternal age are 35 and older if they're having a singleton, 33 and older if they're having a multiple gestation, so it changes a little bit. That just means that they're overall at higher risk for having a baby with a chromosomal problem.
I see.
And so they have to be offered special testing either to just screen for the conditions or diagnose the conditions. And they get a higher level of ultrasound for that as well. Those moms are also at more risk for gestational diabetes and hypertension.
I see.
So we monitor them a little bit closer for that. So that's one of the most common things. We also see diabetics that were pre-existing conditions prior to pregnancy. We see moms with cardiac conditions, with brain conditions, anything that could affect the outcome of the mother. So I always say it's better to have two sets of eyes than just one. So we co-manage, and they see a physician more frequently than someone that's not high risk. So if I don't catch something, Dr. Flores will catch it, and that's how we can have the best outcome possible.
Oh, I think that's great, like a tag team approach.
Tag team,
here.
absolutely.
Yes, And Dr. Flores, you see a lot of, Dr. Velasquez mentioned diabetes a lot in pregnancies, not just in advanced age or high risk, but you certainly see them in others. Why does that occur, and why do we see so much of it, and what can women do when they're pregnant to maybe help reduce that kind of condition?
Yes, so that's a very good question, and I think unfortunately it's a very prevalent condition. We know for a fact that there are some hormones related to pregnancy that will predispose a patient to have diabetes. Of course, a patient that has who is overweight or obese, if we go by the BMI, which is the body mass index, those patients are at increased risk for diabetes in pregnancy. Also, patients who have a pre-existing condition, not per se diabetes, but let's say a patient who is being diagnosed with pre-diabetes, those patients have an increased risk for developing diabetes during pregnancy.
Right.
I think the most important thing that we do when a patient is not pregnant is to give counseling as to how a patient can improve her health in general to have a healthy and uncomplicated pregnancy.
Absolutely.
So I think that's a very important thing to mention. We would like to see more patients before getting pregnant so we can get them in the best condition as far as health to have a healthy pregnancy.
Well, that makes a lot of sense. Sure, to come into a situation healthier is going to have a healthier outcome. So if a woman is planning to become pregnant or has maybe just become pregnant, what can they do to ensure that they have a healthy pregnancy? When you talked about no issues, what does that look like?
So we always advise a healthy diet. If they can have good eating habits, 3 principal meals, 2 snacks in between, having an exercise routine. More important than anything, trying to maintain a healthy weight.
Wow. And what is really a healthy weight for a woman? Is it based on their body index? But you'll hear people say, I gained 30 pounds on my pregnancy, or I only gained this much, or I look at my daughter who is a stick, and she's gained very little weight. So how do you determine what is that you are overweight in your pregnancy?
So we always consider the pre-pregnancy weight, and we based off everything on that.
Okay.
So we go by the body mass index, which is a formula that uses the patient's height and weight. So it gives us an index. An index below 25 is considered a normal weight. From 25 to 29.9 is overweight, and above 30 is obesity. So I think the best thing for a patient to do is trying to maintain their BMI below 25.
Sure. So if you're really planning to start a family, best thing to do is to be healthy, watch your diet. It sounds like almost like a diabetic diet, with 3 meals, a little bit of snacks in between, that's 6 meals a night.
I think all of us would be wise to have a low-carb diet and to be eating at scheduled times, and that helps your metabolism.
I agree with you. I agree. One of the things that we were talking about earlier, I asked you about high risk and advanced age pregnancies, and you were telling me about a pregnancy, one of the oldest that you'd had.
Yes, my oldest patient was 52 with twins.
Oh my goodness.
First pregnancy, did excellent, no complications, carried, well, as close to term. I think we delivered at 35 weeks. No high blood pressure, no diabetes. Did wonderful.
Just perfect.
2 good babies, yes.
Love it. Love that story. One of the things that you all have mentioned is pre-existing conditions or maybe things that could go wrong. And so I know that there's a lot of conversation right now about genetic testing, about looking into what the health of the child is before the birth. So can you talk a little bit about the advantages of genetic testing? Who should have it? Is it something that every pregnant woman should look into? And what are your thoughts?
All genetic testing is optional,
obviously,
because of the implications there. We are afraid of the extremes also of testing just every panel available because of the implications of possibly selecting
you can overtest.
Yes, overtest. So we offer the standard panels. All of us have recessive genes, and so we offer testing for those conditions that could potentially be lethal or have a very severe outcome in the baby, so that the parents can be aware of those conditions beforehand. We offer testing for chromosomal problems to everyone. Some people will choose to take the testing, some of them will not. And it's very family dependent based on how stressed they are about the possible conditions or what they would do about a positive test.
Well, that would make sense to me, of course. And is it, Dr. Flores, is it just a blood test to do this genetic testing? Is it a panel? Is it invasive? Or what is it about?
Yeah, so it's a blood test, and there are several options. The most common test that we use as obstetricians is to determine if the baby has an increased risk for chromosomal abnormalities like Down syndrome, trisomy 18, 13, and other chromosomal problems. We can do a more extended panel to see if the mother of the baby has any conditions that may pass onto the baby.
I see.
And as Dr. Velasquez was mentioning, most of the time, if there is a condition in the parents, they will know it beforehand. They will have some symptoms of the condition. They will probably be told us at a younger age that they have that condition.
So it's really important for them to share this kind of familiar history with you and to give you a full medical background, and you're ascertaining what their needs are and what the direction they should go.
Absolutely.
Sure. Sure.
And and that's something to encourage patients to be forthcoming with the information, because not uncommonly he'll refer someone to me, and then I'll be reviewing the history, and then I'll say, well, how about this? Or is there any family history of abnormalities? And they'll like, oh yes, there is. Well,
yeah,
that's important to know.
Always
we don't
want
like
to
those
tell you the
surprises,
truth, do we? No, that's true.
But we can't evaluate the risk if we don't know.
Know all the facts, absolutely. Right. I want to remind our viewers that we are streaming live on Facebook, and that we are a live call-in show. So the numbers on your screen, 881-0013. Our medical students will be collecting your questions, and you have an opportunity to get some counsel from wonderful physicians here about maternal fetal medicine. So Dr. Velasquez, tell me when the best time for someone who has discovered they're pregnant, when do they need to have an obstetrician? I mean, at what point do you all come into the picture? Immediately, or is it down the road?
For high-risk patients, I like them to tell me as soon as they have a positive pregnancy test, because there are certain conditions that we would want to intervene with immediately.
I see.
Most general OBGYNs would want them at least at a point where we can visualize the pregnancy, which would be about 6 weeks.
Okay.
So that would be a good time frame. Definitely by 12 we would want to see you.
All right. And then Dr. Flores, given that we were talking to you a little bit earlier, this is such a nice topic today, because you were sharing with me that your wife is expecting. And so how does she go about finding a good obstetrician in the community? What does someone need to go to look for? What kind of questions do they need to ask? Because it's a give and take. You want to be comfortable with your doctor. You want someone who's going to listen to you. You really want, this is a long-term, this is a 9-month commitment here, and longer if you're dealing
10 months,
after 10 months. So how does one go about determining the best way to find an obstetrician?
Professionally speaking, I would recommend someone that I know and that I know that that physician does a good work and is a good physician. I think from patient to patient, they go more by experiences of they have a friend that somebody has delivered, so they recommend that person to them. I think it's a good idea if they ask around and share experiences with friends and family.
Word of mouth is so powerful, isn't it? In my day job, I work for the Rio Grande Cancer Foundation, and although we don't recommend doctors or oncologists or anything, we hear in our circles this physician is particularly compassionate, or this one fits my personality because I want to know. I don't want to be kept in the dark. So I think word of mouth and sharing with successful experiences is a real valid way to do that. Yeah. So tell me how you two communicate. So if you've got, you're the maternal fetal expert and you are the obstetrician, how do you all work together?
First of all, he sends a referral, and then we schedule his patient to be seen. And usually he'll just get a letter from me with recommendations. However, if I see that there's something urgent, then I'll either call him or text him so that he can get to me whenever he has a chance.
I see. Very good. So, Dr. Flores, I've got a couple of words here that I'm not familiar with. One of them is a hospitalist, an OB hospitalist program. I've never heard of that before. And of course, there's a lot of things I haven't heard about before. But what is a hospitalist program, and is it important, and why?
A hospitalist program is when a hospital is talking about the obstetric ward. L&D department, they have a physician 24/7 who specializes in obstetrics, taking care of pregnant patients, and also gynecology, everything that is not related to pregnancy. So these physicians are there 24/7 in the hospital, taking care of emergencies, helping physicians that need assistance, let's say for a C-section or for a baby that is not doing well in labor. So I think it's a very safe thing to have, because we always try to make it as soon as possible, but sometimes you can't get there in time.
They don't arrive on your schedule sometimes,
Right.
babies don't,
Yes,
do
yes.
they?
And I
Yeah.
think what you have to realize is that most emergencies in obstetrics are instant.
No.
You can have something that is looking very good and promising and routine, and then in a matter of minutes that goes downhill. And
Kind of like the tornado takes a different
Right.
path.
And so it's
Right.
good to have them there in case something unexpected because it comes up, because that will affect the outcome for the mother and the baby if
I see.
someone's not there.
So tell me your take and your philosophies or even your opinions on, there seems to be a new wave of births and people wanting to birth back at home or utilizing midwife type services, doulas, things of that nature. So I'm curious about what your thoughts are on these alternatives. You know, in our industry, in the cancer business, we use acupunctures and massage and guided imagery and all of these things. And many times the physicians will say, if it makes you feel better, do it, but share with us what is going on. So tell me your philosophy on that kind of services that seem to be kind of enjoying a renaissance, if you will.
Definitely, and I think I saw a lot of patients that seek alternatives in New Mexico and the New Mexico population. I think that it's important to bring in these other I don't know, caregivers that we can take to assist in having a good outcome, as long as the patient is open to intervention should it become necessary.
That's
because,
vital.
Yes, we don't want to
Absolutely.
intervene when it's already too late for mom, too late for baby. So
Right.
it's good to have for people that have birth plans, as long as they're willing to have an open mind and know that everything is not always going to go according to plan, and that it doesn't mean that it's a failure. It just means that we get a good outcome in a different way that wasn't what was anticipated.
Nicely said, absolutely. You know, it's funny as you research things, when I was born and when my sister was born, many times there was no birth plan, there were no choices, etc. And I see now that there are so many options for women to utilize, like a birth plan. I had to look that up. I had to Google birth plan. But is that an important thing to address, an important document to have? And what really is a birth plan?
So a birth plan is basically a list that the woman compiles as to what her desires are. For example, I don't want an IV. I don't want to be connected to the monitors. I would like to labor in a bathtub if available. I don't want epidural anesthesia.
Right.
I don't want an episiotomy. So they come up with all these prerequisites. However, sometimes they're so limiting that the only way that that's going to happen is if she does have a home birth.
Right.
Because we can't be comfortable not monitoring, for example, not monitoring the baby in a situation where the nurse isn't giving one-on-one care.
Sure.
Because if that baby isn't on the monitor and she's with the other patient, then we're not aware of what's going on.
Well, I think to a birth plan, the word plan, plans are made to be flexible and change, and so I think, and babies don't honor what your plans are sometimes. So do you appreciate that in a patient, for them to come in with a birth plan and to have that kind of almost like you know, your wishes on your will, your wishes on what your medical power of attorney might be, or directives, things of that nature? Is it similar to that? Do you as a physician appreciate when a patient does that?
Well, I appreciate more that she tells me that she's having a birth plan,
Okay.
and then we can have a conversation, because most of the time they have false ideas on
Unreasonable expectations.
There
Yeah.
you go.
So a friend told them that possibly an epidural will give him some sort of back pain, and they have these ideas from people that they don't really have a good foundation. So once you table a conversation with them, you tell them what is recommended, what the guidelines are, what is safe to practice, and most of the time they'll take a few things off the list.
Well, that makes sense. You know, in the cancer business, every journey is as individual as the person themselves. And so when somebody says, "Oh, well, don't do that because I had that problem, or I, you know, really suffered from that drug, or that happened to me," that I would imagine it's a similar type of situation in the birthing process, where every birth is unique and individual, and you just don't know what to really expect all the way through. It's rather a journey, isn't it?
It is.
Yeah.
And I've always told my patients when I was delivering patients, it's good to have a non-invasive birth, but why don't you do it in the hospital, where if an emergency happens, we're there and can help you as soon as possible.
Yeah. And your thoughts, Dr. Flores?
Yeah, I think the same.
Because you're getting ready to head that way, aren't you, pretty soon? Yeah. You know, a lot of pregnant women will talk about cravings, that they get cravings, or that something appeals to them or something doesn't. What should pregnant women eat? What should they avoid eating? What kind of, we've talked about a healthy diet, but what should you really be eating during your pregnancy?
Well, again, it goes back to the balanced meal with lean protein.
Okay.
And 3 meals. I usually say 3 meals, 3 snacks, but 2 snacks is okay. And 3 servings of vegetables per meal, if possible. Avoid preservatives.
Ah, okay.
Avoid, there are certain fish that you have to avoid, namely tuna, shark, mackerel.
Anything raw, too, as I understand, is
Well,
kind of...
not always, but it has to be from a good source.
Okay.
But definitely avoid too much tuna, fish, or mackerel, because they're the ones that are higher in mercury content that can affect the fetal nervous system. Pretty much avoid raw meats. So even though you like your steak medium, you can't, because or pork or chicken, because you want to avoid bacteria and avoid parasites.
Sure, sure. Any other thoughts on that, doctor? Anything? Does your wife have cravings right now?
Yeah, she does.
Well, do you have to run to the store for Rocky Road ice cream at the end of the day?
No, I keep my fridge stock.
You were brought up right. Yeah.
Another thing, most patients would like cheese, so we do recommend that they read the label and make sure that they're made with pasteurized milk.
Okay. Wonderful, because yeah, there's a lot of really excellent cheeses out there that are toxic when you're not pregnant. So, talk a little bit about NICU, because a lot of times when we talked about high-risk pregnancies or things of that nature, is there always a NICU? And for the audience, that's neonatal intensive care unit, correct? So immediately, if you are labeled a high risk or a an older patient who's pregnant, does that automatically mean you're going to end up in NICU?
Absolutely not.
Oh, good.
So obviously, if there's a patient that has the potential to have a premature delivery or a baby with complications, we would love to have them oriented as to the NICU so that it's familiar and it's not as scary when the baby arrives.
So you take them through
We
and you
do.
show them, oh, that's fabulous.
But no, just because someone is a high-risk patient doesn't mean that their baby's going to go to NICU, and as a matter of fact, that's what we're trying to prevent. And so that's why we're having more of a frequent visit than if they weren't high risk, so that we can try to get them to term and try to get them to a point where the baby does not need the NICU.
Sure, sure. Excellent. If you are active person, I think, in your life anyway, I would think exercise during pregnancy is probably great. But what if you haven't necessarily been a jockette? Can you start an exercise program? What is your counsel for people who say, well, now I'm pregnant, I've got to stay healthy, I'm going to eat better, I'm eating for two. What are your thoughts, Dr. Flores, on the value of exercise and how one should approach it when they're in a pregnant mode?
So I think exercise is a very important part of any personal health. So I do advise exercise in pregnancy as long as it's safe. I don't recommend climbing mountains or biking in the mountain, things like that.
I don't recommend that either.
Yeah.
No.
So it's something that is safe, and as pregnancy progresses and patient is approaching to term, nothing that will cause any abdominal trauma or will cause a lot of effort from the abdomen.
Right.
So aerobic exercise, swimming is a good exercise, probably
Maybe some
unstationary.
yoga.
Some yoga.
That's good. Stretching, that kind of thing.
Absolutely.
Yeah, great, great. Well, we all need that. So I know we have a question that's come in from the audience, and we want to remind you that you can call in to 881-0013. We'll take your questions here. This viewer has a question that says she has a condition where they have no uterus, and they want to know if there are advances in medicine being considered so that a woman without a uterus can have her own child. Are there uterus transplants on the horizons? This is from our viewers.
Yes, sure. There are uterine transplants now. They have actually had some successful transplants on live donors.
Really?
So let's say that I wanted to give my proven uterus to someone that hasn't had one. We could do that. Or they have had some from cadaver donors as well. But the other option for her, if she has her ovaries, would be to have a surrogate as well.
Well, that's a thought as well. Now, if you do have a uterine transplant, that doesn't simply mean you can carry a child to term then. Have you seen, has there been evidence of a transplant where a child is carried to term?
There has been evidence, but at this point it's still under trials. So
Okay.
it's investigative medicine at this
Right.
point. It's not standard.
Well, down the road we'll be like
the
Star
road.
Trek with all of those
Right.
little machines that they used in those days. I'll give this one to you, Dr. Flores. This is coming from a viewer. What determines the use of amniocentesis?
So amniocentesis is an invasive procedure that is mainly done by specialists like Dr. Velasquez.
Okay.
And that's when we do a genetic test, and that test shows an increased risk for that mother to have, let's say, a Down syndrome baby or a baby with a chromosomal abnormality. So the blood test is only a screening test. It tells us that something is abnormal, but it doesn't give us a diagnosis. An amniocentesis is a diagnostic test that involves retrieving amniotic fluid from the mother's uterus,
Right.
and then examine those cells to visualize each chromosome by chromosome and know exactly what the problem is.
And you're saying it's like a biopsy would be, is that?
With a needle.
With a needle, and you withdraw fluid, and then you're able to determine it. But it comes from the
Amniotic sac.
the amniotic sac.
sac.
Okay.
So
all
in
right.
that amniotic sac, you have baby's cells that have sloughed off from the skin.
Okay.
And so we grow those cells in culture and analyze them. So we can analyze for chromosomes. We can analyze if someone knows that they are a carrier of cystic fibrosis. We can test for that, or whatever condition they have. Some people do it for paternity testing as well. So we
Another
can-
option
yes.
there, right. Right. Well, thank you, viewers. For those, our number, as I remind you, is 881-0013 for any other questions. One of the questions that came up on our list here was, babies don't respect the clock. And they certainly don't respect your time and the fact that you do sleep and do have lives. So what happens, how does a woman know who's really going to deliver her baby?
I think that it all depends on the doctor. So some doctors would cover their practice every single day unless they're out of town.
Right.
And other practices share call. So it's very important to ask your physician that very question, who is going to deliver my baby?
Right.
Because it's usually going to be a group that covers the other patients, well, for all the other doctors that are not on call.
Sure, I would imagine that could be a little bit intimidating to have gone through all of the time with you as the physician, and then at the very end have the what would it be, the B team come in, or the you know, the next line of defense there to come in and deliver the baby. But as you then, I would assume, share your records and talk amongst yourself and have a peer review to talk about these kinds of things, so that they can rest easy, that whoever's going to deliver their baby understands their case and can move that forward.
Yes, and you know, we usually pick people that practice similarly to what we practice, and that we're confident that they're going to take good care of our patients. So we're not going to pick someone that's going to be not of good quality.
I appreciate that.
Yes.
And
we do always try to deliver our patients, because you create a relationship with your patient, and ultimately you want to be there to deliver their babies.
Absolutely.
Yes.
We've had a comfort level. We've talked. I know you, and so I really want you there. Yeah, that would make sense to me. We had another Facebook user send us a question that wanted to know if women with irregular periods have a higher chance of getting pregnant. I guess they're thinking that because you can't really determine when your periods are coming, are you more fertile than other times? What?
It's actually the opposite, because they have more periods or more cycles where they're not ovulating.
Right.
So they usually need assistance in getting pregnant. However, they should not use that as a method of contraception, because every now and then they'll ovulate and they might not be aware and they will get pregnant.
Surprise. Yeah. So I was talking to Dr. Velasquez before you arrived tonight, Dr. Flores, and I was telling her that my daughter sent a picture on my phone. So it's coming across the airways on my phone, this little screen of the sonogram. And I could see so much on that. So there's been a lot of evolution in sonogram, and I know there's 2Ds and 3Ds, but tell us a little bit about the sonogram process now, and why is it so incredibly definitive? And I mean, this child looks like she has long fingers. I can see things. It's just fascinating to me.
Yeah, it's amazing. I'm a fan of ultrasound. I like to do it very much, and it's impressive how technology has advanced in the last 10, 15 years. Nowadays we have actually 4D ultrasound, in which you can see the baby in
4D?
like in a 3D, but with movement. Baby is moving, and usually that is intended not as a not to see baby's face and see how the shape of the nose is. It's intended to be more like a diagnostic test. Let's say we see that a baby has a cardiac malformation, we can use those features to...
You can see that in a sonogram?
You can,
That's
yes.
amazing. Amazing.
Although ultrasounds have limitations as well.
Right.
Yes,
What other
yes.
diagnostic tools do you use? What are at your disposal to find out, and not so much just the health of the baby, but the health of the mom too?
So what we do when we see a pregnant patient for the first time, we need to run a few blood tests to make sure the patient's health in general is in good fit.
Right.
We test for infectious diseases. We check for hemoglobin levels, for the blood type, which is important. We kind of know their vaccination history with some blood tests as well. And throughout the pregnancy, we have different sets of tests that we use to make sure a pregnancy is going well.
Wow. A lot on the upfront side you have to look at.
Yes.
We had a call from a viewer. This is an interesting question. This woman had twins, and one was born with Down syndrome, and the other was not. And they want to know how that was possible. I'm throw it at you, either one of you.
Yes, so those were what we call fraternal twins that happened to be with fertilization of 2 eggs.
Okay.
As opposed to if it had been a monozygotic, which came from 1 egg, then both of them would have either had Downs or have been normal.
I see. So it does happen. It's not a rarity. It certainly can
That would be
happen.
more common than to have the identical ones.
Interesting, interesting. All right, let's see here. Boy or girl? Everyone always wants to know what is the sex of the child, and I know the sonogram you can kind of visualize, but what are you seeing out there? Do people want to know what's going on with their children? Do they feel like they want to know what the sex is, or are we going back to we'll just be surprised when we're there? And how accurate is the tools that, when I'm assuming it's a sonogram, in determining the sex of the baby?
There's more of a trend to not want to know the gender, is what I'm noticing.
My daughter doesn't want to know.
Right.
They want to do yellow at the baby shower.
Exactly,
you know?
or sometimes they want to at least hold off for the gender reveal party.
I've seen those too.
A lot of times the parents won't know, but a family member will know. And I think in my population, it would be very rare to not know the gender, at least after a couple of ultrasounds, because they are scanned in every visit, so it's hard to avoid the genitalia area.
It's yeah. Sometimes you can just tell right off, can't you? Yeah.
Yeah. Nowadays, with blood tests, we can find out the sex of the baby as early as 10, 11 weeks.
Really? Well.
Yes. Yes.
I like the old-fashioned way. I think I'd like to be surprised. Yeah. One of the questions that came in is, what are some of the common conditions that would require a woman to come and see you? Because you are the maternal fetal medicine specialist. If I were just going through a normal pregnancy, I would assume I don't really need as much of your expertise, but what kind of conditions would cause me to seek out your services?
So the most common would be advanced maternal age,
okay,
and diabetes, hypertension, hypothyroid, hyperthyroid, any cardiac condition, any history of a previous stillbirth or recurrent pregnancy losses, people with autoimmune conditions like lupus, rheumatoid arthritis, Sjogren's, scleroderma.
You all have had a recent case with scleroderma?
Yes.
Wow.
So anything that puts mom's health at risk, aneurysm of the brain or previous brain surgery. Sometimes we need evaluation because of hip surgery and just not being able to have a vaginal birth.
Small kind of person with maybe
small
not the
pelvis.
right. Okay.
Yes. And then again, any history of a baby that has an abnormality.
I see.
Okay. Because that, for example, the Downs baby that was mentioned, those babies are more at risk for fetal demise, for passing away in utero, so they would need closer monitoring. For example, babies with gastroschisis, where the intestines are external. Any baby that has an abnormality.
You have anything to add, Dr. Flores, or that's pretty much covered there?
Yeah, that's pretty much covered.
All right. Let's see what I got here. Any more questions from our audience? We're at 881-0013. So tell me a little bit about what the day in the life of an OBGYN looks like. Dr. Flores, what happens when you get to work in the morning? Do you just have a passel of hormonally charged, imbalanced women thrusting through your office? And how much of the focus is now on the inclusion of the father? Because it's not just a solitary thing like it used to be. And you know, you have the baby. I was there for the important part, as Archie Bunker said.
Right.
But tell me what an average day looks like for you.
Yeah. So first of all, every day is an unpredictable
Is it?
day. Yes. For instance, I did a delivery this morning at 3 in the morning.
You look
Then,
great for this time of night.
And then, well, you normally have office hours morning and afternoon, and of course, if you have laboring patients, you take care of them.
Right.
I tend to have a special day for surgeries, and well, you pretty much take it as it comes.
You one surprise after the other, huh?
Yes, yes.
And Dr. Velasquez, tell us a little bit about the labor process too, because I know there was a time when C-sections were just the norm for deliveries, and if you went into labor for longer than X period of time, you had a C-section. But what's the philosophy now? What's considered an average labor time, if there is one, and when does an intervention like a C-section come into place?
Again, I'd like to think that it's individualized according to the patient and the fetus. Most of us know that there's a prodromal labor where people are contracting but not dilating. So, you know, that's not necessarily called labor, but once that cervix starts to dilate, what we're monitoring is to make sure that there is adequate progress and to make sure that there's no sign of infection and that the fetus is tolerating it. So I don't think that any of us really have a time limit, because we are trying to decrease our C-section rate, because it was an inordinate, you know, percentile that we were performing a lot of C-sections. So now most of us are very aware that we want to have a vaginal delivery as long as we're not compromising the mother or the fetus. So for a first-time mom, not out of the ordinary to be laboring probably about 24 hours.
Is that right?
Yeah. Repeat moms, obviously they're a lot faster. They tend to go faster the more children that they have.
So how long were you in the delivery room this morning? And when do you arrive? How long does the lady in labor wait for you to arrive? And because she's got attention, she has people monitoring her, her hospital team is there, everything's in order. When do you actually arrive? And
so I tend to be there as much as possible. Of course, when I have other patients to attend to, the nurses of any hospital in El Paso are more than qualified to help you take care of your patients. So whenever you can't, they'll help you assessing them and telling you how much progression in her cervical dilation, the center of the head, and usually you tend to be there right before a patient is ready to start pushing, just so you don't miss a delivery.
Wow. Well, you know, I'm a big fan of public TV and some of the shows they do, and the BBC. And so I'm wondering if either one of you watched Call the Midwife, that was on BBC for many, many seasons, about a little London after the World War II and the Nonantas nuns who provided all the midwifery services. It was a fascinating reflection on how our times have changed over the course of time and some of the things that they went through. I remember a particular episode where they are treating women for nausea with thalidomide.
Oh, wow.
And you're thinking, no, it's a trap, don't go. So talk about some of the meds that are available now. What's the safety of them? Women who suffer with a lot of maybe nausea, early morning sickness, things of that nature. What's out there now that's, and I hate to always say safe, but what's effective and is considered a good alternative?
So we have medications that are safe, but we always start with, you know, homeopathic if possible.
Okay.
So, you know, the diet has a lot to do with it, avoiding spicy food, timed meals, you know, bland diet, crackers first thing in the morning. Ginger is very good. So once they've exhausted that, then we go to different medications, and there are several. Most of them are safe. That's the key to always, for anything, any medication that you may be on, bring it up to your physician so that we can evaluate whether that's safe in pregnancy or not, because we can always choose an alternative.
Wonderful. Yeah. Your thoughts, doctor? Any other?
Yes, I think as Dr. Velasquez said, we have different options, and through the years we've found that they're safe to use in pregnancy. But we always like to start with diet changes and things like that.
It always comes back to diet, doesn't it? I've read recently there was a report on cancer and some of the reduction in different kinds of cancers, but elevation in other, and one of the most key findings was the obesity factor. So we just need to change a little bit on our diet. So talk a little bit about getting pregnant. Now I realize that you're not in that field, because that would be someone that helps someone get pregnant, but if people are considering a pregnancy, what should they be doing to prepare themselves in order to have a healthy birth?
So I think, again, it's a tag team situation here. Most people that are high risk should know that it is possible to have what we call a preconception visit, where they come to see me and we evaluate any risk factors that they have that may have implications for the pregnancy, so that we are aware of them before the person gets pregnant, and that we have a plan in mind so that once that pregnancy occurs, we can have a good outcome.
Oh, that makes a lot of sense. And that's a service that you offer, a preconception visit. Oh, that makes a lot of sense. Anything to add, doctor?
Yes, so in the preconception visit, we can make sure the patient is in a good health to get pregnant. We can possibly treat some conditions that are difficult to treat when a patient does get pregnant.
Okay, and talk a little bit about after the fact, because there is pre-pregnancy, there is care during pregnancy, and what happens after a baby is delivered, and what kind of care does a mother need after the birth takes place? And is that your role, or do we send this person back to their gynecologist? It goes to you, Dr. Flores.
Yes, so once a patient delivers, we consider that patient to be in the postpartum period, which lasts about 40 days. And we do need to have frequent visits to make sure things are going well.
Sure.
Because there are certain things that may happen in the postpartum period. Let's say a patient can develop hypertension even after she has delivered her baby. Patient can suffer some conditions like postpartum depression.
Sure.
If she has some thyroid conditions, postpartum period might exacerbate thyroid problems. And
so you could have an underactive or an overactive thyroid, is that what you're saying?
Yes.
Or, oh, okay.
Yes.
But that's all, does that go away after a period of time, or is that something that you find you need to treat? Or is it just part of the postpartum process?
Postpartum process may exacerbate the condition
I see.
a little bit.
Okay.
And that's something that needs to be treated possibly for life.
Yeah, and folks do have, there seems to be a real preponderance toward postpartum depression. That's kind of a normal thing. When does it not become normal? I mean, all of us get a little blue and down, and
Yes.
going through what your body has been through has got to be such a challenge on you. But what's a normal period of depression, and when should one really look to seek more help from that condition?
So postpartum blues is something that can happen 10 to 12 days after the delivery date. Anything that passes those 12 days and it has a worsening in the symptoms of the patient should be evaluated and treated, because postpartum depression can be really dangerous to the mother and to the baby.
Of course, of course. Any other thoughts from you, Doctor?
Yeah, the other thought as far as evaluating the period, the postpartum period, a very good point that was made with the findings that the maternal mortality is increasing in Texas instead of going down.
Really?
In the United States in general, and in particular in Texas. So one of the things that we think is contributing to that is that we only see the patient for those 6 weeks postpartum, and that they only have sometimes coverage, insurance coverage
Sure.
for that 6 weeks. So then they fall through the cracks, because we should, per se, consider the postpartum period for about a year after that they
Really?
have, because people will develop the postpartum depression, or people that were, for example, preeclamptic will develop heart failure, you know, so
Sure.
the conditions that we discovered in pregnancy will go on to affect the morbidity of that patient, and sometimes it's that 1 year time span that we're missing, and so people don't have coverage.
Well, it's good to know, because you know, you think that there's some magic number after your body should return back to normal and you should be feeling the way you are. You've got this lovely bundle of joy, and yet up to a year that someone could suffer that kind of condition. What do you do for your patients, doctor, when they have that kind of postpartum depression?
So first of all, you need to be really careful and diagnose those patients. So there are different tools we can use to see how severe is that patient's depression, and you should start treatment right away and refer that patient to a psychiatrist.
Yes.
To kind of help with the management of the condition.
Right.
Sometimes you have to admit those patients to be watched in the hospital.
Golly.
And I
Yes.
think a point that we need to make is to not be afraid to bring it up, because sometimes it's still considered taboo, and people are afraid to say, you know, I'm not happy to have this baby here.
Thank you for making that point.
And so we need to make them aware that it's not something that they're doing wrong. It's something that's usually made worse by the hormones,
Right.
and it's a medical condition, and we need to treat it as such.
I think thank you for sharing that with the viewers, because that is valid. We have a tendency, not that depression postpartum is mental health, but it falls under that realm, and we still have a lot of stigma in that field, and a lot of people who just won't come forward on that because it makes them appear to be weak, or they don't want to appear to be a bad mom, or whatever it might be. So we have a couple of questions from our audience, and these just come straight out, so I'm not quite sure how to proof them here. This one says, if a woman has thickening of the amniotic fluid with bands, what effect can this have on the baby, and why does this happen? That seems like a very specific question, and I'll toss it up. Do either one of you want to tackle this?
Sure. I mean, I think what they're talking about is an amniotic band, where there is like a separation of that sac that, as they said, kind of thickens. And what worries us is that it can serve as a tourniquet for the baby. So if the baby gets entangled in that, it can cause amputations. So you more commonly will see a baby that's missing a hand or missing a foot. Worst case scenario, a cleft in the face. So they can cause some birth abnormalities.
Wow. All right. Hope we addressed that for that. And they asked, why does it happen? Do we have any idea
It's
why?
just an injury to the development of that placenta and the membranes.
Sometimes there's just no reason, is
Right.
there? Right. And Dr. Flores, I'll give you this one. Again, these come straight out of the
Okay.
phone, so I'm not sure. It says here, if a woman has multiple fetuses, triplets, quadruplets, what are the chances that just one could be unhealthy or have a disease?
Well, the higher the number of babies, the higher the complications, and of course, the higher the chances of a baby having any condition, not only genetic, but what we call spontaneous or not genetic related. So I think Dr. Velasquez will agree with me that the healthiest pregnancy is a single-term pregnancy.
Okay.
Yes, there are some tests that you can do to find out if a baby is affected, like an amniocentesis. But yes, the higher the number of babies, the higher the chances of complications.
It would make sense, sure. You see
Yes.
the stories of the quadruplets or the triplets or the
Octomom.
Octomom and where they are now, and I've seen them, and a lot of them have issues and hearing loss, or they wear glasses at a young age, whatever it might be. So that would make sense to me.
And a lot of that has to do with prematurity. So the higher the number, the earlier they're going to be born, and the bigger
Sure.
the injury to the brain.
Yes. And talk a little bit about just that, because you do, not all women carry to full term. So if they do not, what are the options for them? You see a lot of these little ones in the NICU units who struggle, but ultimately really come out well. There seems to be a lot of advances in that. And what is the encouraging thing to let women know about maybe if they don't make it to full term?
Right. So the encouraging thing is that we have excellent neonatologists, and we have excellent NICUs in town, and will take care of their babies from the OB perspective and from the neonatal perspective. The youngest baby that I've ever had with a good outcome was 11 ounces. So that was very impressive. We try to get, to 24 weeks is what we determine as viability, where the baby can survive outside of the mom. By the time we get to 28 weeks, we have a very good chance of a good outcome, about 80%. Then our target would be to get to 32 weeks,
Right.
because those 32 weekers, when you follow them in the long term as far as intellectual capacity, they tend to be functioning as well as a full-term baby. Now remember that not all full-term babies are normal either.
Sure.
So our goal would be to get to a minimum of 32 weeks where we can get a good outcome.
And you concur with that, Doctor?
Yes,
Yeah.
I do.
Well, I know we're getting ready. We're close to the mark here. So anything else you'd like to share with our viewers? Anything we haven't covered tonight that wasn't on my list of questions for you tonight that you just want to share with women who are in pregnancy or considering pregnancy, but final thoughts on that?
I think mostly get early prenatal care, be open with your physician about any family history or personal history, and try to be compliant with the recommendations of the doctor. Find a doctor that suits your personality, because that's very important. You have to be comfortable with the physician that's taking care of you so that you can trust them and trust their recommendations.
I agree. Any other thoughts from you, Doctor?
Yeah, I would say same as Dr. Velasquez, to get a prenatal care as early as possible, to as much as possible get that preconception evaluation to make sure things in general are in good shape for that patient to get pregnant.
Well, I know we talked about your 52-year-old mom, but what's one of your most memorable journeys with a pregnancy? What's one that sticks in your mind as either just a joyous thing and something that I'm sure you walk away from every birth feeling joyous. That's got to be one of the most remarkable feelings to see life at the beginning like that. But you have anything you want to share with this, doctor, about a good journey that you've encountered?
Yes, I do remember a patient who was pregnant when I was a resident, and she had a monozygotic twin pregnancy. That means that both babies were in the same amniotic sac, so they were sharing.
And usually they're in two different sacs, is that it?
Yes.
Oh,
So
okay.
that is more common, and a monozygotic twin pregnancy has higher chances of complications, and in this case the umbilical cord of the baby is getting entangled. So that patient spent 4.5 months in labor and delivery on continuous monitoring until she delivered.
And the outcome was
good.
positive?
Yeah,
And
it
how
was
long
positive.
ago was that?
About 3 years ago.
I often wonder when you see the old country docs on the movies of the weeks, whatever, they've got all the pictures on their wall of all the babies they've delivered. So what's your count up to now?
I don't have a count, but believe it or not, because of HIPAA, they usually
I
don't
can't
let
ask
us
that question.
They don't let us put, identifying pictures up there unless we have a
Bummer.
permission from the patient.
Oh golly. How about you, doctor? How many do you figure are in on your notches on your belt?
I would say since I started training, more than 1,000 for sure.
Really? Wow.
Yes, yes.
That's amazing. That's just amazing. Well, anything else you would like to add, or any final thoughts you have? I think we're down to just a minute. I need to wrap us up. You have been watching the El Paso Physician with Dr. Maria Velasquez and Dr. Andres Flores. If you are looking for someone who is in neonatal and perinatal medicine, Dr. Velasquez is your go-to gal, and Dr. Flores partners with her on that. We want to thank you for viewing today and remind you that you can view this show by going to the El Paso Physician show on, I don't have my notes here, so I've forgotten on Facebook. You can go on Facebook to click onto that. You can also view this. This show will be archived, and so you can go back in and watch that later. Thank you very much. I'm getting cues over here, so you can go to kcos.org and watch the remainder of the show. Thank you so much for joining us today. You've been watching the El Paso Physician. Thank you and good night.